Good evening, dear my professional colleagues, and thank you, the Jardians Division of Boringa Ringalam, uh, for inviting me to be the speaker of this evening. And I am Dr. Sepuri Mohan. I am an endocrinologist at my own Sepuri Diabetes and Endocrine Center, Kurnool. So today we are going to talk about the molecule, actually the empagliflozin, uh, the SGLT2 inhibitor, as all of you know. And today we are going to talk about the holistic cardio-renal, metabolic and hepatic care in type 2 diabetes mellitus, empowering patient-centric outcomes. And here is a case scenario. Actually, you can see a prototype 45-year-old male patient, and he has got a medical history of type 2 diabetes of 1 year duration, and with a moderately active lifestyle, unknown case of dyslipidemia for more than 10 years. Hypertension, the comorbidities, the dyslipidemia is there, and hypertension in the last 5 years, and history of excessive daytime sleepiness, and family history of heart failure in mother. So BMI and the waist circumference, BMI is 30 kilogram per meter square, and the waist circumference is 40 inches, and blood pressure at the clinic is 130/80 millimeters of mercury. And the hemoglobin is 9 grams, and the platelet count is 1,59,000. And the glycemic profile, if we take the glycemic triad, which includes the fasting and the post-lunch and the HbA1c, the A1c is around 8%. So at the age of 45, literally it is higher. Okay. And post-prandial fasting is 134 milligram per deciliter, and a very little bit marginal elevation, and postprandial glucose is 189 milligram per deciliter, very marginal elevation. And lipid profile, total cholesterol 173 milligram per deciliter, and the LDLC is 92 milligram per deciliter. As per the latest recommendations, it is high, should be less than 70 in a case of diabetes with no comorbidities. And HDL is 44, it's okay. For males it is 40, and females it should be more than 50 milligram per deciliter. And triglycerides very marginally elevated, 185 milligram per deciliter. The liver assessment, SGOT is 36, SGPT 41, grade 1 fatty liver and ultrasound abdomen. The urine albumin creatinine ratio is 90 milligram per grams, that is increased. You see, earlier we used to call the microalbuminuria, and now the ADA has replaced this particular term microalbuminuria by urine albumin creatinine ratio. So less than 30 is normal, 30 to 300 is microalbuminuria. So, and more than that, more than 300 is macroalbuminuria. So then, see, 30 to the 300, so now it is 90, it is moderately increased albuminuria. And serum creatinine is 1.5 milligram per deciliter, and the estimated glomerular filtration rate according to the CKD-EPI algorithm, it is 58 ml per minute per 1.73 meter square the surface body area. So it falls under the category of grade the stage 3A DKD. So, and with decreased EGFR of 4 ml per minute in the past year. So the recent ECG, that is treadmill, is positive, that suggests a query silent myocardial ischemia. Okay. See, treadmill is a very decisive test. See, we have seen people just dying during the treadmill actually. So the latest algorithm what the developed countries are they are adopting is, they take an ECG, 12 lead resting electrocardiogram followed by 2D echo, and something is suspicious, they straight away go to either the CT angiography, coronary angiography, or the MRI angiography, or the direct radial coronary angiogram. So the current therapy, the patient is on metformin, telmisartan, chlorthalidone and atorvastatin in the tolerated doses. So the ectopic fat, this slide shows the ectopic fat and the insulin resistance increase the cardio-renal, metabolic and hepatic risk. All the time you add please hepatic, because CRM itself is not sufficient, renal metabolic is not sufficient. It also includes the hepatic risk. So you can see in the center, the inflammatory metabolic risk and obesity, they lead to a lot of problems. On the left hand side, you can see the heart failure and the atrial fibrillation with hypoperfusion and the cardiovascular volume overload and the arterial resistance and the neurochromonal activation. Coming to the right hand side, the chronic kidney disease is characterized by albuminuria, the fluid retention, the oxidative stress, the RAS and the sympathetic nervous system activation. And down below it is the atherosclerosis and acute coronary syndrome ACS in the form of regenerative cell exhaustion and the plaque instability. And coming to the right hand side on the down below is NASH and NAFLD, and the nomenclature is the last year they have changed actually. So it was changed once in 2020. The last year the international the association of this hepatologists and the scientists who are working for this the NASH and the NAFLD, they have changed the nomenclature, but still I don't think it has come into the textbooks. So NAFLD is replaced, NAFLD and NASH are replaced by MASLD, MASLD, that is metabolically deficient associated steatotic liver disease. So that includes the increased free fatty acids and the lipotoxicity and the insulin resistance. Okay. The cardiorenal, metabolic and the hepatic comorbidities and the complications in T2DM. So the center you find that cartoon like people with type 2DM, they have got the renal problems and the metabolic problems, and the renal problems in the form of the chronic kidney disease or the diabetic kidney disease, and the cardiovascular problems in the form of either the 3-point MACE or the 4-point MACE or the 5-point MACE, and the heart failure, either it is acute heart failure or chronic heart failure, and hospitalization for heart failure HHF. And on the other hand, the obesity and the metabolic and on the liver, it is what I said, the metabolically defective associated steatotic liver disease. So on the left hand side, you can see in people with the type 2 diabetes, we see the incident at least once in 3 have CKD, very pathetic. So as the 40 years ago, as we have studied that type 2 diabetes mellitus is coronary equivalent. Some say it is not so, but still we need to agree that. And now the latest funda is pre-diabetes is cardiac equivalent. And at least 1 in 8 with normal eGFR level will develop a rapid decline in the eGFR. At least 1 in 2 cases of CKD have only low to low moderate level of albuminuria. And in people with type 2 diabetes, at least 1 in 7 have heart failure. Nearly 1 in 2 have left ventricular diastolic dysfunction. Let it be grade 1 or grade 2 or grade 3, whatever it may be. And one more thing, they have got the left ventricular systolic dysfunction also. So coming on to the right hand side, the metabolic problems, the people with type 2 diabetes, nearly 3 in 5 have MASLD. This is very pathetic. 3 in 5 have MASLD. Nearly 1 in 4 have clinically significant liver fibrosis. And nearly 2 in 3 have diabetic dyslipidemia. And in patients with type 2 diabetes, nearly 1 in 3 have the cardiovascular disease. At least 1 in 5 have the coronary artery disease. At least 1 in 2 will have the cardiovascular death. And this slide shows the screening for cardiometabolic and the hepatic risk status in adults. The measurement of BMI and waist circumference annually, and you should calculate, you should take the waist circumference as well as the hip circumference, and you should calculate the WHR, like how you measure BMI from height and weight, height in centimeters, weight in kilos, you get BMI. Likewise, the waist circumference and the hip circumference, that gives you the waist, the WHR, waist circumference ratio. This should be done annually. I suggest at least once in 3 months you should do. Whenever the patient comes, you please measure that. You are not going to lose anything by measuring that. And metabolic syndrome components like the increased blood pressure, the increased triglycerides, and the increased the low HDL and the dysglycemia, and every 3 to 5 years more frequently with the progressive CRMH risk levels, and advanced liver fibrosis related to MASLD using FIB4 index every 1 to 2 years, and urine albumin creatinine ratio and the serum creatinine bar the cystatin C based EGFR levels. See, this is picking up actually. The cystatin C is the most accurate one, but I don't think in our country it has not picked up at all. So we are supposed to measure the cystatin C levels, where in the developed countries like the European Union and the American people, that is the US, they particularly calculate this cystatin C based EGFR levels and the creatinine based EGFR level annually, more frequently as required. And subclinical heart failure like echocardiogram or the cardiac biomarkers likely based on the age, comorbidity and risk. So 2D echogram will give you a very good the picture of the subclinical heart failure. And coronary artery calcium and intermediate cardiovascular risk to guide intensification of the preventive therapies. Social determinants of health. And coming to this next slide, this shows the holistic approach to cardio-renal, metabolic and hepatic care in the elderly suffering from the type 2 diabetes mellitus. On the left hand side you see the cartoon. We have seen already the people with type 2 diabetes, they do suffer from the cardiovascular complications in the form of 3-point MACE, 4-point MACE, 5-point MACE, and the acute heart failure or chronic heart failure, and the renal complications like either the chronic kidney disease or the diabetic kidney disease, and the metabolic, and then the hepatic in the form of the metabolically defective associated steato liver disease and the obesity. And the right hand side you find the lifestyle management is very, very important. Instead of lifestyle management, the correct term is the therapeutic lifestyle changes. TLC is the changes like diet, exercise and reduction in the weight, cessation of smoking if applicable, cessation of alcohol if applicable. So LSM means only it's diet and exercise. So just smoking, tobacco cessation and physical activity and diet management. And more than that, it is very important that the weight is reduced actually. So reduction of weight by 7% is going to help in the long run actually. 7% of the existing body weight. So essential treatment for risk factor control, it's lipid management. See, always remember ABC. So it's not just enough if you treat diabetes successfully. The fasting is good and post lunch is good and the A1C is good. It is not enough. The A stands for the A1C, B stands for blood pressure, and C stands for cholesterol. And definitely the next one is you need to look for the liver parameters. apart from ABC. Now the latest addition is hepatic parameters. And essential treatment for risk factor control, see what I said, the weight management and the BP reduction, the glycemic control and the lipid management. And the essential treatment for organ protection, that includes the SGLT2 inhibitors and the GLP-1 receptor agonists and the RAS blockade and the non-steroidal the mineralocorticoid receptor antagonists. That is the all of you know the spironolactone, you know, and eplerenone is one, and the finerenone is the very budding molecule with a lot of future. Finerenone. Please, somebody is making noise, so please, may I request to maintain silence, please, in the interest of audience, please. Please mute yourself, okay? Early coordinated treatment is crucial to improve the patient outcomes and the quality of life. And the effects of SGLT2 inhibition, all of you know that, right? Okay. So the SGLT2 inhibition on the kidneys, it increases the erythropoietin and glycosuria. So the renal glycosuria is increased wherein depending upon the molecule use, it is from 60 to 120 grams in 24 hours. So that leads to the glucose in the urine, the presence of glucose in the urine in the form of 1 plus to 4 plus, it may be the patient who is on SGLT2 inhibitors. That is the reason why the patient reduces the weight. So a lot of glucose is being excreted, and it decreases the interstitial fluid and the albuminuria, and it decreases the plasma volume and the body water, and it increases the uricosauria. Thereby the uric acid levels are reduced, which is a favorable phenomena with SGLT2 inhibition. And then the increases natriuresis, and it increases diuresis, and it decreases the sodium hydrogen exchanger 3, that is, and it increases the CKD progression or DKD progression, and decreases the ketonuria. And on the adipose tissue, it increases the lipolysis, decreases the epicardial fat and body weight, and blood plasma, it reduces the inflammation and oxidative damage, and increases the erythropoiesis and hematocrit. And the liver, it decreases the steatosis and increases the ketone bodies. At the level of pancreas, it increases the glucagon, so there is no hypoglycemia absolutely, and it reduces the A1C, and it reduces the fasting plasma glucose and the postprandial glucose, and it reduces the insulin. And the level of blood vessels, the vasodilatation is increased, and the increased RAS activity with increased endothelial function, with decreased sympathetic tone and decreased blood pressure. So these are the multiple effects what we see with the SGLT2 inhibition. At the level of heart, the preload is reduced and the afterload is reduced, and it reduces the arrhythmias and reduces the NHE1, and it reduces the hypertrophy and the cardiac hypertrophy, and it reduces the oxygen demand and decreases the fibrosis, and the preload and afterload is very much decreased. So these are the multiple effects of SGLT2 inhibition. There is also SGLT1 inhibition, but which is not very significant. So these are all SGLT2 inhibitors. See, starting from the canagliflozin to empagliflozin to dapagliflozin, which are present in the country, and there are many which are not available in our country. So the US and the Canada and the European Union, a lot of the other molecules like etugliflozin is there, ipragliflozin is, vipragliflozin, so many, the sotagliflozin, that is the one molecule sotagliflozin which has got the unique the characteristic feature of the inhibition at SGLT2 and SGLT1, because the thing is the SGLT2 are present at the proximal convoluted tubules in the juxtaglomerular apparatus, the PCT, whereas the SGLT1 receptor is present at the proximal straight tubule. So sotagliflozin is the one molecule which acts at the level of both. See, per se, I am telling you SGLT2 inhibitors are to be used only in patients suffering from type 2 diabetes mellitus. See, forget about the scenario in the Europe, you forget about the scenario in the America, because European Union has long been using all these molecules along with sotagliflozin in type 1 patients along with insulin. And what they have seen is, they have seen the insulin dosage going down and down. But all the time you should be very cautious about the euglycemic decay in the type 1 or even the type 2 also. And the patient should never get dehydrated. So these are the few, and the contraindications of this particular SGLT2 inhibitors in type 2 diabetes. It is if the patient is dehydrated, you cannot, because it has got a natriuretic effect and the osmotic diuretic effect, and the patient has got recurrent genitourinary tract infection or the candidal infections like the balanitis or fasciitis or the balanopasciitis in men, vulvitis or vaginitis or vulvovaginitis in the women. If it is very, very recurrent, that is one of the contraindications of this particular SGLT2 inhibitors. So this is the slide. The bar diagram shows the greater HbA1c level reductions with empagliflozin, sitagliptin at various baseline HbA1c levels in type 2 diabetes. You can very clearly see this. The black being the empagliflozin, and the green being the sitagliptin. So you can see the reduction of HbA1c by 0.87 in the bar diagram when compared to 0.71 respectively with the sitagliptin. And as the the first one is the baseline of A1C at the level of 8%, second is at 9%, last is 10%. As the A1C goes up, the reductions are high. That is the take-home message. See, you can see the reductions of A1C where the baseline HbA1c is around 9. The reduction is 1.36 with empagliflozin and 1 with sitagliptin. And if it is 10, the A1C is 10, it is 1.85% reduction with the empagliflozin, and respectively 1.28 with sitagliptin. So for every 1% increase in the baseline of the HbA1c, the corresponding HbA1c reduction at 24 weeks, the empagliflozin they used is all the trials they have used only 25 milligram, never at 10 milligram, and the sitagliptin is 100 milligram. So the reduction is by the 0.49%, and the sitagliptin it is 0.29%. Significantly higher efficacy with empagliflozin versus this sitagliptin, because see, two are different molecules. Like one is a DPP4 inhibitor, the gliptins. Like this second is the SGLT2 inhibitors, which are called the gliflozins. So this cartoon shows the empagliflozin improves time in range. See, TIR is very, very important nowadays. See, the three things which are very, very important, which have picked up in the last 5 years are the time in range, the glycemic variability, and the blood pressure variability. You have to keep in mind all these three things. So the time above the range is bad, time below the range is bad. That is hyperglycemia, this is hypoglycemia. Time in range, TIR, maintaining the empagliflozin improves TIR in uncontrolled type 2 diabetes. Benefit on 24-hour continuous glucose monitoring is observed from day 1 onwards. You can clearly see the time above the range is red actually. So that is around or more than 180 milligrams per deciliter according to the international guidelines. And the green is the within the time range, that is around or more than 70 to less than 180 milligram per deciliter. And the time below range is the grey one, that is less than 70 milligram per deciliter, which is per se the definition of ambulatory hypoglycemia. So that is L1 hypoglycemia, level 1 hypoglycemia. So you can clearly see at the baseline and the day 1 and the day 28, you can clearly see that empagliflozin 10 milligram and the placebo when compared to the 25 milligram, it has shown that the most of the time the patients are within the time range. This is the take-home measures from this slide. So the empagliflozin rapidly clears glucometabolic toxicity and improves beta cell function in people with type 2 diabetes. And the clinical parameters are like the fasting plasma glucose and the C-peptide response and the beta cell function and the beta cell glucose sensitivity. The measured is they are the baseline and on day 2 and day 14. You can clearly see the difference. All the clinical parameters, there is a beneficial effect with this particular empagliflozin by reducing the glucometabolic toxicity and improving the beta cell function in the patients suffering from type 2 diabetes mellitus. So the empagliflozin with metformin results in a sustained weight loss. This bar diagram clearly shows the empagliflozin versus the glimepiride as add-on to metformin in T2DM. So the glimepiride was used in the dose of 1 to 4 milligram and empagliflozin standard. The red is the glimepiride and the navy blue, I think, dark blue is empagliflozin. You can very clearly see the two graphs getting separated from the beginning. That is from day 1 itself, the curves are going in a different direction altogether. So this is the beneficial effect with this particular empagliflozin with metformin. The sustained weight loss versus the glimepiride as add-on to metformin. On the one hand, it is the empagliflozin and metformin. On the other hand, it is glimepiride and metformin. So there are two more studies with glimepiride. You just have to remember always the linagliptin, the two cardiovascular outcome trials. The one is Carolina and the second is Carmelina. The Carolina is done with the linagliptin and the one arm and the glimepiride and the second arm. Two are the cardiovascular outcome trials, but Carmelina is with the high risk for cardiovascular disease and the Carolina is low risk for cardiovascular disease. That is the only difference. And empagliflozin reduces the hepatic fat content in people with type 2 diabetes and I said metabolically deficient associated steatotic liver disease, that is ELIP study. You can very clearly see the control on the empagliflozin. So it reduced the fat content in people with type 2 diabetes with the steatotic liver disease. So the significant reduction you can see the first one is the p-value being 0.054, that is statistically significant, though not insignificant or very significant. But when you take the second bar diagram, the p-value is 0.0001, that is statistically very different, significant. So the ELIP study is a randomized controlled trial in 42 patients and the people suffering from the type 2 diabetes and the MASLD, empagliflozin versus standard treatment control for 20 weeks and 4% greater absolute reduction in the liver fat achieved with empagliflozin versus control group, where the p-value is 0.001 and it is statistically very significant. 18% of the patients using empagliflozin achieved a normal liver fat content versus 5% of the people achieved in the control group. So it is very significantly very significant. So empagliflozin reduces the liver fat content as compared to sitagliptin in people with type 2 diabetes mellitus and the metabolic associated fatty liver disease. See, there are two terms actually. See, 2020 it was MAFLD and 2023 it is MASLD. the meaning is one and same. Even you say non-alcoholic steatohepatitis and the non-alcoholic fatty liver disease, NASH and the NAFLD, and they have changed the term metabolically. This is MAFLD, and now the latest term is MASLD. So you can clearly see the empagliflozin and the sitagliptin, the intrahepatic lipid content is very much reduced by using this particular the baseline when compared to the therapy with empagliflozin in green, the baseline and in the black. You can clearly see the difference in the effect is around a reduction by 5.2%. The p-value is 0.001, which is statistically very significant, whereas with sitagliptin it was able to reduce 1.6%. The p-value is not significant, so it is not even 0.05, not even. So this is again a bar diagram. Empagliflozin use improves insulin sensitivity in people with type 2 diabetes mellitus and the high insulin resistance. Changes in the insulin sensitivity parameters with empagliflozin versus the placebo from baseline to 12 weeks. And the insulin sensitivity or the resistance is calculated by means of the HOMA-IR and the fasting insulin level and the remnant-like cholesterol. So you can very clearly see the differences in the HOMA-IR, where it is reduced by 23.1%. Fasting insulin level with empagliflozin reduced by 30.7 respectively, and the remnant-like cholesterol reduced by 31.8% respectively. So empagliflozin helps BP goal achievement in resistant hypertension in patients with type 2 diabetes mellitus with cardiovascular disease. This is taken from EMPIRIC outcome. So the landmark trial is EMPIRIC, and the next second trial is the EMPIRIC outcome, and the next is the Emperor HF, and the next is the EMPA kidney. These are the landmark trials done with empagliflozin, and the BP lowering effect of empagliflozin at week 12, the patients with the type 2 diabetes and resistant hypertension, you can clearly see there is the very significant reduction in the systolic BP, but this is not as significant as in case of diastolic BP. So there is significant 24-hour BP in the terms of systolic BP reductions, with marginal diastolic reductions with the gliflozins, especially with the empagliflozin, and the patients with type 2 diabetes and resistant hypertension in EMPIRIC outcome trial, the 129 out of 418 in patients on placebo and 379 out of 1004 patients on empagliflozin achieved SBP goal of less than 130 millimeters of mercury at the 12th week. So this is the empagliflozin reduces the risk of CV death early in patients with type 2 diabetes and the cardiovascular time. Again taken from the inference is from EMPIRIC outcome trial. And the overall study population, the 38% relative risk reduction. And on the right hand side you can see the Asian patients of group 56 relative risk reduction. The greatest point to be noted here is the take home message is the DPP4 inhibition and the SGLT2 inhibition is much better in the Asian continent, especially our Indian the continent, subcontinent, when compared to the Caucasians. That is the take home message. Okay, so you can see the curves getting much separated in the Asian population. So the much DPP4 inhibition as well as the SGLT2 inhibition is seen in the Asians when compared to the Caucasians. So these are the very efficacious drugs for our scenario, which is the most suited actually. And these are all the okay, again the analysis taken from the empiric outcome term 25. Empagliflozin reduces the risk of first and recurrent cardiovascular events in patients with type 2 diabetes and atherosclerotic cardiovascular disease. Again, so these are all the empagliflozin consistently improves the MACE outcomes in patients with cardiovascular disease. So again, these are all the beneficial effects. Empagliflozin use reduces the risk of the cardiovascular death and the hospitalization for the heart failure in patients with heart failure across the left ventricular ejection fraction spectrum. That is the Emperor study. That's what I just now mentioned. And the emperor preserved and the emperor reduced actually. So initiating empagliflozin at hospital discharge in hemodynamically stable patients of heart failure leads to 30% greater likelihood of clinical benefit, that is impulse actually. So the one take home message here, at the time of discharge you start this particular one only the patient is very very stable. This is a cardiologist perspective. We are not treating the acute cases. And it shows the all-cause mortality rate over 90 days and HF event over 90 days. So again, empagliflozin use before hospital discharge in hemodynamically stable patients of acute HF does not worsen overall safety outcomes. Again, taken from Impulse. And empagliflozin significantly reduces the risk of ESRD or ESKD, end-stage kidney disease or the end-stage renal disease, or the cardiovascular death in patients suffering from the chronic kidney disease or the diabetic kidney disease at the risk of progression. This is what I said, EMPA kidney. It's a landmark trial with this empagliflozin, whereas with the DAPA it is DAPA CKD, which was done earlier actually, and much earlier was done with the canagliflozin, that was Credence actually. These are the three studies done on kidney. The Credence with canagliflozin, DAPA CKD with the dapagliflozin, and the EMPA kidney is with empagliflozin. So EMPA kidney is the largest and most inclusive CKD trial to date actually. So the US FDA was so happy to see the results with even the dapagliflozin and the empagliflozin, that is DAPA CKD and EMPA kidney. It asked both the people like the dapagliflozin that belongs to AstraZeneca and the EMPA is the Boehringer Ingelheim. So it asked these two companies to stop the trial, seeing the overwhelming response, the very positive response on the benefits on the kidney. So prematurely the study was stopped even 6 months prior to that, and probably this is the only the one study which is prematurely stopped by the US FDA. So these are the, and empagliflozin significantly slows the EGFR decline in patients suffering from the chronic kidney disease and the diabetic kidney disease across different urine normal creatinine ratio levels and primary cause of CKD, that is EMPA kidney. But here is a take-home message I'll tell you. Once you start this particular SGLT2 inhibitors, either the canagliflozin or the dapagliflozin or the empagliflozin, whatever it may be, so there will be initial decline in the EGFR by 10 to 20% within the first 2 to 4 weeks. So don't get depressed by that. It's a practical aspect. First it goes down and then the EGFR increases in the long run, and it's very very stable. So now the cutoff, earlier it was 45, the EGFR was 40, above 45, around or above 45 ml per minute, and later on it became 30. Now the cutoff is to start an SGLT2 inhibitor, gliflozin is 20 ml per minute of EGFR. So the empagliflozin use may potentially delay the SKD up to 27 years and avoid 4,000 plus hemodialysis sessions in patients with the CKD, the EMPA kidney. They see these are all the beneficial effects. See how much of the EGFR, the improvement and the potential delay in the kidney failure and potentially avoidable the hemodialysis sessions. See, you can just go through the table. These are figures showing that it has got a lot of documented evidence-based medicine. And empagliflozin leads to more than 50% lower odds of the rapid decline in the eGFR in patients with the type 2 diabetes mellitus and the cardiovascular disease. Again, from empiric outcome, you can very clearly see that the placebo is gray and the pooled empagliflozin is red. You can clearly see the reductions actually. And empagliflozin causes significant regression in the albuminuria in patients with type 2 diabetes and the cardiovascular disease with prior albuminuria, again taken from empiric outcome. And you can see the curves getting separated from the beginning. The placebo and the empagliflozin on the left hand side, and on the right hand side also the placebo is in the green and the the placebo is in the blue and the empa is in the red actually. So 43% of increased likelihood with empagliflozin. So 82% of increased likelihood with empagliflozin on the right hand side. That is patients with prior macroalbuminuria on the right hand side and the patients with prior microalbuminuria on the left hand side. So empagliflozin consistently improves the cardiorenal and hepatic outcomes irrespective of the initial eGFR dip actually. This is again from empiric outcome. Empagliflozin improves cardiac autonomic neuropathy outcomes. This is taken from SCAN study. SCAN is nothing but cardiac autonomic neuropathy. So you can simply make out this cardiac autonomic neuropathy by just taking a resting 12-lead electrocardiogram where you find the sinus tachycardia in the patients suffering from the type 2 diabetes and the variations in the blood pressure. The very less variations like in the supine and the prone and then the sitting and the standing, all these positions you take that, and that shows you the clinically how you can make out the cardiac neuropathy, including the vasovagal syncope actually. So it improves to that extent that majority of the vasovagal syncope incidence is very much reduced after using empagliflozin. And empagliflozin lowers the new onset of OSA, that is obstructive sleep apnea syndrome. And empagliflozin versus placebo, you can very clearly see the placebo being in the grey and the red is in the pooled. You can see the reductions with the graphic representation with this empagliflozin. The changes in the weight, SBP, hematocrit and HbA1c only partly explain this observed benefit. Okay. So in patients with the type 2 diabetes and atherosclerotic cardiovascular disease, only empagliflozin has proven significant 38% of risk reduction for CV death. This is very, very significant. 38% of risk reduction with the cardiovascular death taken in the patients of type 2 diabetes mellitus with aggressive atherosclerotic cardiovascular disease, AA CVD. Okay. And the SGLT2 inhibitors and the cardiorenal outcomes in type 2 diabetes and the atherosclerotic cardiovascular outcome trial summary for patients suffering from type 2 diabetes and atherosclerotic cardiovascular disease in SGLT2 in that is the cardiovascular outcome trials. See, the empiric and the empagliflozin and the canvas is canagliflozin, declared TB 58 and the Verti CV. These are the basic studies actually, basic cardiovascular outcome trials with this particular this thing. So still it's a question whether this particular the reductions in the 3-point MACE and the reductions in the heart failure and the HHF is a class effect or a drug effect, because the empagliflozin and the dapagliflozin showed more or less head-to-head fight, whereas a little bit behind is canagliflozin. And what is CV came out with the etugliflozin, there was very disappointing results actually, especially with regards to the all-cause mortality and the cardiovascular death and the major adverse cardiovascular events. And there was only the positive finding being the hospitalization for heart failure, where retogliflozin showed a significant similar effect at par with the other gliflozins. So we take the major adverse cardiovascular events, the cardiovascular death and all-cause mortality and hospitalization for heart failure and chronic kidney outcomes. See, with the empagliflozin EMPA-REG outcome, it has shown 14% with the major adverse risk reduction and 38% cardiovascular death, very significant. All-cause mortality by 32%, which is huge actually. Hospitalization for heart failure is 35%, and chronic kidney outcomes by 46% risk reduction. Likewise, canagliflozin, it showed 18% risk reduction in the major adverse cardiovascular events, and whereas CV death is not significant, all-cause mortality not significant. Hospitalization for heart failure was 32%. Chronic kidney outcomes was good in credence, so that was 41%, and declared to me not significant at all with major adverse CV events. In the declared TIMI 58. I am talking about the basic CVOTs. And the CV death also was not significant. All-cause mortality was not significant. And hospitalization for heart failure was only 22%, and chronic kidney outcomes 45% risk reduction. And later on, the subsequent studies with this particular the dapagliflozin, DAPA-HF and the DAPA-CKD has shown very, very significant positive results actually. And what is CV? I said it's a disappointing one. Okay, so still it is used in the US, United States. The empagliflozin demonstrates a lower risk of ESKD, CV death and HHF and the ACM, and the similar risk of MI, stroke compared to GLP-1 receptor agonists in type 2 diabetes. This is EMPRISE actually, the cardiorenal outcomes with empagliflozin versus GLP-1 receptor agonist in patients with type 2 diabetes mellitus. You can clearly see the empagliflozin in the black, and then the green is GLP-1 receptor agonist. The first parameter is cardiovascular death and HHF. You can see a significant reduction and compared to the GLP-1 receptor agonist. ESKD also, it has got wonderful effect, the gliflozin, empagliflozin. Whereas CV death, it is more or less, it is head to neck fight actually. So CV death was not that because GLP-1 receptor agonists, they are very wonderful drugs as far as the aggressive atherosclerotic cardiovascular disease is concerned. So if you combine both the SGLT2 inhibitors and the GLP-1 receptor agonists, it has got a wonderful synergistic effect, and better than the using one molecule. You better use two molecules. In high-risk cases, you get wonderful results. And the all-cause mortality, it was 13.6 with empagliflozin, and the GLP-1 receptors 15.4. Likewise, MI and stroke 31.1 and respectively 13.4. And empagliflozin demonstrated consistent safety profile in the patients with the type 2 diabetes mellitus CKD. Again, pooled analysis of placebo-controlled clinical trials. Adverse events with empagliflozin versus placebo in T2D with CKD stage 3 G3A. So you can clearly see the favorable effects, the placebo in the black and the EMPA in the green. See, all the reductions are very, very significant, and especially the edema and the hyperkalemia are terribly significant. And this is the American Diabetes Association Standards of Care in Diabetes 2024 actually. You can get it in the Diabetes Care January edition. So that gives the standards of care every year, and that releases in the internet much earlier. Like by 15th December, it releases the guidelines actually. You stay there. Stay there. It's about to. So again, this is the ADA standards of care in diabetes. Now that the first international scientific body that said irrespective of metformin, initiation of metformin, either SGLT2 inhibitors or the GLP-1 receptor can be initiated in patients with the at risk of developing atherosclerotic cardiovascular disease or the heart failures without even metformin was the European Society of Cardiology way back in 2019. Even before the COVID, it said that these are the molecules to be used. If the atherosclerotic cardiovascular disease predominates, you have to go for GLP-1 receptors, and the heart failure predominates, you go for SGLT2 inhibitors. It's always better to combine these both, GLP-1 receptor agonists and the SGLT2 inhibitors. So later on, the European Association for the Study of Diabetes joined hands and they came out with a joint consensus. ESC bar EASD 2019 guidelines, they said you avoid metformin, you start with this either one of the molecules or the two molecules to have the better effects. And later on ADA also, and the ACE, that is American College of Endocrinology, and AAH, that is the American Association for the Clinical Endocrinologists, and even the American Heart Association have joined hands with that. They have got the giant algorithm like AHA bar EACC guidelines, giant consensus has given that okay, they never said skip metformin and go for that, and after metformin the next drug to be used is SGLT2 inhibitor. The patient is at risk of developing the atherosclerotic ASCVD or the heart failure or the HHF or the established atherosclerotic cardiovascular disease with either the HF or HHF. So after that, see, this is the one, and next drug to be added is the DPP4. Now we have got wonderful combinations with this particular the metformin sustained release 1000 milligrams, either the dapagliflozin 10 milligrams and the sitagliptin 100 milligram combination, one single pill, one go. So the greatest advantage of the SGLT2 inhibition is if you start very early in the disease course, the patient is benefited to the maximum. If you start late in the course, like after 20-30 years of diabetes, you add a SGLT2 inhibitor, it only acts as a glucose lowering agent. Beyond that, no protection on the heart, no protection on the kidney, no protection on the uric acid, no protection on the liver. So take home message is, see, I've got lot of experience with all these molecules day to day in the OPD. We very regularly put every patient on this particular the SGLT2 inhibitors and the DPP4 inhibitors and the metformin. So use them early in the course of the disease, type 2 diabetes, or else there is no use using that. And there are certain contraindications, I said. When the patient is dehydrated, when the patient is in decay, you cannot use. When the patient is in has got the recurrent GUTIs or the balanitis, fasciitis, candidal infections, or the vulvopasciitis or vulvitis, vaginitis, vulvovaginitis. These are the contraindications, because all the companies, they highlight only the positive points. They try to suppress the negative points, but I wanted to highlight because it is clinically very, very, very important. And back to the case, and then holistic benefits of adding empagliflozin on top of standard care of medicine in 100 such patients with type 2 diabetes and CVD for 3 years. 100 patients with type 2 diabetes mellitus and CVD 3 years has resulted in the 9.8 cardiovascular events prevented, 8.5 CKD events are prevented, and 3.4 the acute kidney injury or the acute renal failure or the hyperkalemia events were prevented, and 12.9 insulin requirement was prevented, and 5.1 it is additional SBP goals achieved in resistant hypertension. That is the reason it is a very good add-on therapy to nocturnal hypertension, which is very, very dangerous, and the true resistant hypertension. Most of the times, what we see in clinical scenario is not the real resistant hypertension, it is pseudo resistant hypertension. Patient might not be taking the tablets, he is not complaint at all, no tolerance at all, and the no dash diet and nothing, no exercise, nothing is. So, so this is the SGLT2 inhibitor empagliflozin reduces the systolic BP very significantly, so that it is a very good add-on therapy to the standard care of the nocturnal hypertension or the essential hypertension or the resistant hypertension. So 5.5 the reductions in the edema and the new obstructive sleep apnea events prevented, and 3.4 total additional life years gained. These are the benefits. And okay, this is the boring information. And thank you so much. And thank you so much for your patient listening. I request all the participants, if you have any questions or queries, please put it in the chat box so that I'll take up the QA session, question and answer session after 2 minutes. Thank you so much.